recording?
Please record it.
No.
Okay.
Okay. Morning, everybody. I'm Dr. Salazar, the attending physician.
I'm Dr. Gavieres, the chief of staff.
I'm Dr. Vieta, the intern.
And I'm Dr. Martinez, the resident, and this is case 342. Our patient is a 78-year-old African-American male that was brought into our facility by his wife. Our patient presented to us with memory loss. His wife stated that his memory loss began with him forgetting where he placed certain things, and then him forgetting close friends and family members' names. Our patient's symptoms soon progressed to him doing childlike things, such as him scratching his face, wiping his nose with the back of his hand, and also putting up his eyebrows. When our patient's wife brought him into our facility, she quoted that it might be Alzheimer's. My colleague, Mercedes Viera, will talk to you about our differential diagnosis.
Our top three differential diagnoses: Alzheimer's disease, Huntington's disease, and glioblastoma. Alzheimer's disease is a mental disorder that occurs between middle and old age. This disease is the most common cause of dementia. A group of thinking and social symptoms that interferes with daily functionings. Even though signs and symptoms were similar, this was ruled out when we performed an MRI, and we will talk about the MRI in later. I don't know how you want me to say that, because you didn't want me to say about the tumor.
We'll just able to talk about the MRI when Dr. Gutierrez discusses the final diagnosis.
Okay, that. Our next differential diagnosis is Huntington's disease. Huntington's disease is a hereditary disease that occurs between 30s and 40s. This disease interferes with daily functioning and results in movement, cognitive, and psychiatric disorders. This was ruled out because our patient did not inherit the disease. Our next differential diagnosis is glioblastoma. Glioblastoma is a malignant tumor. This tumor is very cancerous and causes the breakdown of nerve cells in the brain. This was not ruled out because of the symptoms and how similar it was to our patient, but soon to be fully ruled out when we found out that glioblastoma is a symptom of intracranial neoplasm, which is our final diagnosis that my colleague Dr. Gutierrez did not talk about.
Our final diagnosis was intracranial neoplasm. I completed the patient's neurologic exam, and I started with his mental status. A mental status exam is a series of tests and questions that test the patient's cognitive abilities. It's scored 0 to 30, and anything above a 20 is considered good. Our patient scored a 12 out of 30, and although he was alert, awake, and responsive, he was unable to tell me what month it was, what city we were in, and who the president was. He could not remember 3 objects that I had just asked him to. He could not spell body backwards. He could not perform a 3-step command, and he refused to write his name for me. I then tested the patient's cranial nerve functions by completing a fundoscopic exam of both eyes. The patient was not cooperative, so I was unable to successfully complete my exam, but from what I could see, both pupils seemed normal. I then tested the patient's extraocular movements, and he was able to follow my finger in all areas of gaze, and he tested positive for nystagmus. His facial reflexes, hearing, palate evaluation, and spinal evaluation all seemed normal, as well as his tongue strength and protrusion. I then tested the patient's motor abilities, and all muscles in the upper extremities seemed to have good strength. The muscles in his lower extremities were unable to be assessed due to incorporation. He could not stand on his own without bilateral support. I then tested his reflexes. The reflexes in the upper and lower extremities had hyperreflexia, and his reflexes in his ankles were unable to be assessed. The reflexes in the soles of his feet were decreasing bilaterally. I then moved on to the patient's sensory. All limbs tested positive. The patient tested tested equally for painful stimuli in all 4 limbs. Next is the cerebellar exam. The patient was unable to determine distances bilaterally in the upper extremities when reaching for objects, and he tested negative for swaying of the head and trunk of the body when sitting up straight. Lastly, I tested the patient's evaluation of gait and sense of position. He was very unsteady, and although he did take 2 steps on his own, it was very difficult for him. And he could not stand on his own without bilateral support. Due to my results, I sent our patient to receive an MRI, which allowed us to see that there was a large mass on both frontal lobes. I then sent my patient to receive a stereotactic needle biopsy, which tested positive for hypercellularity, angiogenesis, pleomorphism, nephrosis with glioblastoma multiforme, which is the growth of an abnormal growth of excess cells, the death of all or most cells in the tissue due to disease, and the form of a highly malignant tumor. Next, my colleague, Dr. Martinez, will talk to you about the clinical course.
Since our patient was diagnosed with intracranial neoplasm, his family decided to send him to a hospice facility. A hospice facility is a home-based clinic that is generally used for patients in their terminal stage. Since our patient will be sent here, he'll be receiving various amounts of pain medications to keep him comfortable.
Are we missing something from clinical course, like he got a deep vein thrombosis? So that might need to be added.
Okay. So like what happened, why they decided to just go straight to hospice?
Yeah,
Okay.
that needs to be before, so hospice would be here, but so over the course of our patient's stay with us, he developed a deep vein thrombosis in his lower left leg, I think, or something to that nature. And so you would talk about that. The family decided to place the patient in hospice care, and then you would talk about hospice.
Okay.
So you do talk about the deep vein thrombosis. That would be you, still on your slide.
So I say it, and then since our patient developed a deep vein thrombosis in his lower leg, the family decided to send him to hospice care.
Because of both, right? So he had the deep vein thrombosis.
I think
He had a stroke, didn't he? He had a deep vein thrombosis, which led to a stroke, coupled with the brain cancer, essentially.
Okay.
They're sending him to hospice care. He's also old,
Okay.
but don't say that.
Paralysis.
Yeah.
After the stroke.
Okay.
So that's why they sent him to hospice. You see how there's like a chunk missing?
Yeah. Okay.
Okay.
Now I do. My colleague I do. I was going to talk to you about the social code notifications.
According to Washington State University School of Medicine, men being blue are more prone to brain cancer than
Men being blue on this chart. That's when you say men being blue.
well, I point at it.
Yeah, but just say men being blue on this chart, just so people, because some people don't connect the dots.
So men being blue on this chart are more prone to brain cancer. This is because cancer preventing protein known as glioblastoma is less active in males than females. This is due to the sexual difference between the two.
Just start for more information.
I said just call the number.
Just say, for more information, you can reach out to the American Brain Tumor Association, whose goal is to find a cure for brain tumors. They participate in payroll giving, stock donations, and charitable shopping. Their number is there, and their website is braincancer.org, whatever it is. All right, give me a second before you leave. Okay. This concludes our discussion. Are there any questions? You need to go over that last slide. I need to see that before tomorrow. Mercedes, what happened to your slide?